All right. Hi, everyone. I'm Catherine Ellis, and I'm here with
Margaret Adams.
Cool. And so Margaret had asked me to jump on and have some conversation about sexuality and occupational therapy. And Margaret, if you just want to chat like briefly about your project and then fire away with the questions.
Absolutely. So I'm at a regional inpatient rehab center on the East Coast for my doctoral capstone, specializing in sexuality for spinal cord injury patients. And as part of my DCE, I wanted to interview a therapist that's kind of leading the way in terms of sexuality for OT. So I reached out to Catherine and she was gracious enough to let me interview her. So we thought we'd record this so other people could have the same access.
Yeah, awesome. I was all about it.
All right. So my first question, Catherine, is what do you recommend for students advocating for sexuality when they are still learning themselves? Especially, I can attest to that as a student right now. I'm still learning the ropes, and it feels a little awkward sometimes to try and teach therapists that have been treating for years.
I understand. So you're asking like they're still learning about how to do the interventions, or they're still learning about like themselves as a sexual person?
Doing interventions, even just like regular everyday, ADL interventions.
I see. So like oftentimes I think students are put in the position with these capstone projects to like educate clinicians or talk about intervention when that's not really something that they have experience with. I would probably say the biggest thing is, of course, like get exposure, like just like what you're doing. Unfortunately, because a lot of clinicians aren't doing this work, like you just have to do imperfect action. That's what I call it. So like when we just think about the learning process, we always have to do practice. We always have to practice. And that can feel really scary, especially like when we're under supervision, because it's a lot easier to like practice and kind of stumble along when like you're the only OT in the room. There's like a few things, that kind of make that difficult. But I would just say the best advice is just like being empathetic towards yourself and saying like, okay, like I'm not going to be perfect in this. And this is also all part of the learning process. And it sounds like my CI is also learning. So we're just going to learn together. I would say that like, this isn't, when you're learning anything, you have to practice, and there's no better time than when you're a student.
Absolutely. All right. And next question was, how do you advocate? There we go.
I'm back.
Oh, there we go.
It's still recording, so I don't know. Okay.
Did you hear that last question?
No, I didn't.
Okay. So I said, how do you advocate for your private outpatient services? Because I think that's a really unique situation that you have. That's, very common in the OT world if it's not, outpatient ortho or peds.
Okay, so it is not common. And so it's been a long history. So I worked at Walter Reed National Military Medical Center for 9 years. And almost day one, I worked in acute care, the hospital setting. So day one, I started addressing sex and intimacy with my clients. Like I said, like I didn't really know what I was doing, but I just wanted to open the door for my clients to talk to me about it. Mm-hmm. And then that's where it started. And about 5 years later was when I started, like I had a full outpatient schedule with just sex and intimacy clients. So it takes these things take a long time. It was a long time of me doing the interventions, telling my supervisors and my leadership that it was effective, telling my leadership that it was needed. Sometimes it's just staffing things. Like I had to switch. Someone was in outpatient and they wanted to come inpatient. And so I switched with them. And really just like advocating that the position is necessary, but also just knowing that this took many meetings, a lot of like documentation that this was effective. And also like, one thing that I thought was strategic was that I started getting outpatient referrals before I was technically fully outpatient. Mm-hmm. And so once you start, I did a bunch of in-services, and this is just in the hospital that I was in. I did a bunch of in-services with other departments, educating them on the services that I do. before I was even like fully doing the services, so you have to build it. And this is what it looks like when you're building it from scratch. So once I started getting in the referrals, now there's a referral stream, and that's important to the clinic. And so it was really through getting a bunch of referrals that then I said, hey, I'm needed down here. I'm needed in outpatient full time.
Yeah.
And so programming just takes a long time. And now, fast forward to where I am now. Now I have my own private practice, and I do the same thing. I meet providers in the area. I network with them, buy them coffee, tell them about the service that I do, and then they'll send me referrals.
I see. Yeah, because I think that what you're doing is so amazing, but not everybody has access to you.
Yeah.
Living on the East Coast. I think about Alaska especially, but other places, because that's where I'm from. But there's not a lot of opportunities for that. I think that there are there are sexuality therapists, more psychotherapists in most places, but they don't necessarily know how to address things the way that we do, and especially with patients that it might be something more physical. So I think that's a really wonderful niche that you've made.
Yeah.
So. And then that leads into my next question. Where and when do you think sexuality should be addressed more in depth?
So I think, like sexuality can be addressed. Think about it like throughout like the whole treatment session. So, it depends on the setting too. So like I would probably bring it up. I used to, when I worked inpatient, I would bring it up during initial evaluation, either at the beginning when I was talking about occupational therapy, or towards the end when I would be like, oh, also some people with your insert diagnosis or surgery or, reason for being admitted, like have questions about sex and intimacy, like, do you, or let me know. And so then it just kind of opens the door, and they may say like, no, I don't have any questions. Or let's just take someone that's in acute rehab, right? Maybe they say no, and then you bring it up at every reevaluation. So you're just like touching base with them and saying, hey, last time you said you don't have any questions or concerns, like how has that changed, or how has that changed? There is no wrong time. There's no wrong time to bring it up. Yeah. Having him like the more in-depth conversation, I would say like that's for, when I bring it up with clients, I bring it up in a public open air setting. Whether the nurse is in the room, whether mom and dad are in the room, grandma and grandpa or grandma and grandma are in the room, like I bring it up, right? But if someone then says like, yes, I have more questions, then I would say like, okay, do we want to find a private space? So like in a clinic, like an outpatient clinic where there's tons of people, I would bring it up. But if they then say, yes, they have questions, then it's like, okay, well, it sounds like maybe we would want to find a private spot to have this conversation.
Absolutely.
And I think a lot of people have that. A lot of research says that healthcare providers say that they don't have enough privacy to bring up the topic. And it's really interesting that we have a perception that we need privacy to do it, which I think asking people about toileting is kind of intimate. I think when doctors like ask all sorts of intimate questions in public with people coming in and out of the room. So, I'm not sure why sex is any different.
Absolutely. And going on to that, what do you feel is OT's scope with sexuality? Obviously, we do, share some of the responsibility, especially with spinal cord injury patients. They see a lot of times urology. Yeah. We can't provide some of the medical interventions that some spinal cord injury patients would need. So where do you feel like we lie in that spectrum?
Especially like with that example, I think a lot of like OT's job is to carry over that education and make that education manageable for the client. And so that we can like confirm that the client, has all the information and is able to make decisions. Like, so perhaps some of that like sexual health decision making we can help with, helping them weigh the pros and cons. I also think like a lot of doctors prescribe, a lot of providers, like I'm including maybe like physical therapy or, a dietitianist, right? Like they prescribe a medication, an exercise, a certain way to eat, but people don't always like, that's not always so easily integrated into their daily life, so using like, for someone that has erectile dysfunction, like using Viagra or using a injection or a pump, like they may not know how to sequence that into their sexual routine. And that pump or that ED medication may just sit in their bedside table and they never use it.
Absolutely.
And then the doctor says like, oh, like non-compliant or never used it, and it's like, no, they just like, they need help sequencing into their daily routine. So I think for that specific example, that's like a huge area that OT can work on. And then also like helping them process like, well, how do you feel about using the, kind of helping them build their awareness of like how they're feeling about themselves.
Mm-hmm. And then next is, do you think how should students or practitioners market their experience in sexuality? If a practitioner or student comes out of school or their last job and is applying to a new position, is that something we should advocate in our interviews, or how should we advocate it? Because I think it's something that certainly a different generation of OTs might not be as comfortable with. And I think I personally, as a student, have had fear sometimes in saying to some of my previous CIs, I'm going to do sexuality because I don't want to make anybody uncomfortable. Sure. Right? We have that bias. So,
yeah. And I think, so I think what you're saying is like when students are really passionate about the topic or a new clinician, then like you're going to your first job interview, like, do you, so I mean, that's really interesting question. I would say, the ability to talk about, like for you to talk about sexuality in a way that is comfortable and normalizing, it speaks volumes to the interview process or to the group, right? So like if we sit there and we're kind of like uncomfortable talking about sex, then everybody else is. And we can be really uncomfortable inside, but on the outside, we just have to be like, I did my field work at a CARF accredited rehab center for spinal cord injury. And I did my project on sexuality and intimacy, like just very matter of factly, like we were talking about sensory processing or vision therapy or driving rehab. And so I think it's really helpful, like just to be very objective about it. Mm-hmm. I think like, it's hard, right? Like, you have to ask yourself, do you really want to work at a place where if you like, that if you brought up sex and intimacy in an interview, you wouldn't get the job. Like, so you would ask yourself, do I really want to work there? Mm-hmm. I mean, sometimes we don't always have the luxury of like really choosing, where we're working. And I'm well aware of that. So I think you just kind of have to, the person has to figure out like what they, the pros and cons of like sharing and like how they want to do that. But if you do, just the more objective you are about it, the better. And I know a lot of students, so many students have said that like they brought up sex in an interview and the person that interviewing them was like, oh my gosh, that's great. Like we really need somebody that's doing that. So it was like a really positive response.
Yeah. And that's what it seems to be. But I think that we have to be aware of our own fear and our own bias with it, even if we want to address it, that we just assume that everybody else is going to have an issue because, as you said, that's often not the case. So,
yeah.
And then what are tips you would give to students or new practitioners in creating informational materials for patients?
Yeah, I mean, other than like readability and like font size and making sure that it's like, a color that people, other than like the sort of general accessibility, like infographic stuff, I would say that you want to, I mean, I think infographics are so powerful, but they use images a lot, right? And we want to make sure that images are not just like a heterosexual cisgender white people. So making sure that your images aren't just like reflecting an ethnocentric, or sorry, well, depending on your identities, an ethnocentric, but Eurocentric kind of view. So I think that's like really helpful. And honestly, like the thing that I have found the most helpful is just getting other people to do external reviews of my infographics, because I am limited by my own experiences and identities. And so I have a whole host of people that I lean on and pay to review my work, my presentations, my images, infographics. I'm not necessarily saying like, sometimes we don't always have those resources, but definitely like asking people to contribute or reflect on your work before providing it to patients. So I think that's really important. I think, we always just have to be clear about like, what's the information we want to give people. And so I think people need help with like just a bunch of strategies. So just making sure that it's like very strategy heavy. Yeah.
Absolutely. And then is there such a thing as too much information?
Like too much information on an infographic, or like when you're doing an interview, or like when you're doing a treatment session, like too much information?
I would say probably more on the infographic. I think that, especially with patients that are a little bit more uncomfortable and at first don't want to talk to you about it, we kind of go immediately to handing them an infographic, which is helpful, especially if they are uncomfortable with, the discussion. But it's kind of hard to gauge, am I throwing way too much at them in this infographic, or is it going to freak people out, or is the language too casual, that sort of thing.
Yeah. I mean, I would say casual language is probably pretty good. Like, we don't want to make this like super rigid. It's sex, like, and we don't want to make it feel like scientific or academic, because I think that's off-putting. Yeah. I would say like, yeah, there probably is something as too much information. You don't, with an infographic, like you don't want to get super specific. You do want people to like read it and think like, oh, maybe I have more questions, and then ask you about it. So like take a balance between the two. I certainly, I think that there's a lot of, I caution being overly cautious because I think that can prevent us from just doing what we were trained to do. Like if you were writing a handout about, reading when you have low vision, what would you want the person to know? And take out, that's, or would you be asking those questions with that? You know what I mean? So I think sometimes we can really like, and I've done it so often too, like kind of like second guess myself. Am I doing too much? Am I not doing enough? Am I going to offend somebody? And I think that a lot of that will prevent us from actually like doing the work and then practicing, because the reality is that you could put on an infographic, make an infographic, and then your patients will give you feedback. And then in 6 months, you change the infographic. So you need, your patients will tell you like, this was busy looking, or, there's too much going on. Like, they'll tell you. Yeah.
That's awesome. And then next, actually kind of with the casual language, do you primarily use more casual language or medical, just especially with varying patients and ages, things like that?
Yeah, no, I mean, I try to use the language that they use unless I find the language really offensive. So long as I'm comfortable using it, I'll use the language that they use. I think that what can happen is if we continue to use language that's like, good therapeutic use of self tells you to use the language that your clients are using. So long as it like feels authentic to you. But, so that goes for like, if you say testicles and they say balls, so if I'm saying testicles and they're saying balls, it's like balls, testicles. And it's like, what are we even talking about? Like, most people know what ball or testicles are, but like you also run the risk of like talking about two different things.
Yeah.
So you do need to have common language and then clarify, like, okay, like when you use this term, like what are you referring to if you need help clarifying?
Absolutely.
Yeah.
And then how do we overcome barriers within the treatment team with addressing sexuality?
Yeah. So like other providers or people from the treatment team that aren't supportive of addressing sex and intimacy, or they sort of like tell OT to just handle it and then like laugh and snicker.
A bit of the former.
Okay.
I definitely think it's also not so much that necessarily people are negative about it, but we'll just push it off and say, it's the next settings job. It's outpatient.
Okay.
It's the next.
Yeah. I mean, there's so much research that says that participants or people want clinicians to bring it up, and they want people to bring it up early on. Mm-hmm. So you can show them that research. You can also show them the research that says that like when people are injured or for people that have disabilities, when it isn't addressed, they take offense to that. That sort of like asexualization of people that are in the hospital, wounded, ill, injured, have a disability, that's very offensive to them and very harmful and very hurtful. So I would really just focus on the impact of the person. This is harmful. This is not effective healthcare. This creates health disparities. I mean, I would be as like grave as possible because we're not just talking about like good sex. Like we're not just talking about like, oh, they're going to go like hit the hay. Like there's some really serious outcomes, both positive and negative, of a positive, of like sexual health rehabilitation.
Absolutely. And I see it a lot in some of our patients that, they say we don't have enough time. And I don't disagree that, especially with the shortening length of stays in inpatient rehab, that, we are cramped on time. But, when your patient is taking a 3-minute, rested seated break, or if you're taking 3 minutes to document, you can take a minute and a half to introduce sexuality at least and ask them if they have questions.
Absolutely. We that's fabulous. Like just get creative. Like do a standing exercise and grooming exercise while talking about sex. Like, you can't do that with every client, but like a lot of clients that you could.
Yeah, exactly. Yeah. And, it gets a little tedious, I think, for clients to be doing the same thing. And a lot of our clients that, their biggest barrier is transfers, and they need to do 4 transfers in a session, and it's exhausting. You got to add something to it to make it
absolutely
not the same thing.
Yeah, absolutely.
So, yeah. And then my last question I have written here is, how do we address biases from ourselves and from our patients?
That's a great question. Okay, so biases from ourselves, like one, if you've identified a bias, you're already on the right track. Like, congratulations, you're doing it right. Please identify more because you have more. So like if you have a brain, you have a bias. I don't think, in OT school, we're taught a lot of times we're taught to think about the other or the patient and how they're different from us, but we never really think about ourselves as like a sexual being or a cultural being or entity. So do your own self-awareness and learn about yourself, because your norm is your norm only, nobody else's norm. But when it's our norm, we can often think that like that's the norm. So that's where we have biases. So do your self-awareness, process yourself, and that's a continual process that never ends. So long as we're OTs, we should be doing that. And then, so reconciling the bias. So I would say one is just acknowledging that like multiple viewpoints can coexist without threats to each other. So you can have a belief that you are entitled to that is very different from my belief that I'm entitled to, but they can both coexist. They're not absolute truths. They're perceptions and perspectives and viewpoints that are my truths, but they're not like the truths. So they can coexist in the same space. Then I would also say we have to lean on our code of ethics. So we have autonomy. All of our code of ethics could apply to biases, but I like to talk about autonomy because that's really like we want our clients to be self-determined. We want to create environments where they're able to choose and that they do choose what is authentic to them, because we know that influences quality of life positively. So there you go. So that's the application of autonomy in its finest, is when it feels like, it goes against, like your feelings. That's how we can reconcile it. And I would also say too, when it comes to my own beliefs, like I'm allowed to have them, but they have no bearing on the therapeutic process. When I'm acting as an occupational therapist, I'm an occupational therapist. I'm not this other entity. And so, it's thinking like, I in this moment, that belief system is not influential. And so that's kind of the one. And then if people can't work through it and can't figure it out past that one, I would say that this isn't the profession for you. Like if you can't navigate your own biases, which is normal to have, so that it doesn't influence the therapeutic relationship, then you shouldn't be in the profession, because that's kind of like OT and therapeutic self 101. Yeah. Now, our clients' bias, do you have any like reflections or comments on that?
That
was a lot.
No, absolutely. I think where I run into a little bit of trouble is thinking about how to acknowledge and respect beyond just biases, but also different religious beliefs of practitioners themselves and what they will be comfortable addressing. And, I've spoken to my CI about that a decent amount, and just kind of saying, like everybody in our opinion should be able to at least tell the patient that OTs address this, but maybe I'm not the right OT. And so that's just kind of what I've worked through is, you, like you said, you are allowed to be yourself, and not everybody can work with every single patient, but to at least know that, and know that you can say, I will find you somebody better, not just leave them. Because you can't just be like, if I can't do it, nobody can.
Yeah. I mean, and I think that some of that depends. Like when you have a big clinic and a lot of OTs, no, not everybody is a specialist in sex and intimacy. So you have like a point of contact. That you function in a clinic where that is being addressed. Yes. So if you are not comfortable going beyond permission, that's okay, because you do. And I love what you were saying is like, you should be able to go to permission and then send the client to another person. Mm-hmm. This changes when you're the only OT in a clinic. Yes. And I would say that if your religious beliefs prevent you from addressing this topic with your client population, then it sounds like you need a different job. Not necessarily a different OT job, but you're like, that dynamic is hard because you're the only OT there, you know? So we don't, and, I just think like these are great questions that you're asking, but I do think that it comes back to the scope of practice and back to our code of ethics. And I know that there are a lot of religious beliefs that really empower people to talk about sex and intimacy. And there's religious beliefs that don't, right?
Absolutely.
And I think here are my opinion as one opinion among many others. Like, please seek out other OTs and other people's opinions, but mine stands as this is within our scope of practice. We don't get to pick and choose what we do or do not talk about. If I don't want to work on toileting, then I would not work at a job where I had to work on toileting.
Absolutely.
So if you do not want to talk about sex, then I don't know what OT job doesn't focus on sexuality, but I think you get my point.
Yes, yes, absolutely. And I had professors in school that said I was not a big fan of toileting. I went into hands.
Exactly.
But he had a bowel accident at the clinic one day, and he was the only OT at the clinic. So guess who got,
right.
sent to help the person with a bowel accident. So I think that's a really good kind of comparison. It's like you can find a job where you don't feel like you're going to address the things that you're not super comfortable with, but you need to be prepared for having some background in it.
Yeah, you do. Absolutely.
So, and then the other one was from patients. Yeah.
Well, so maybe I need an example, but maybe I need an example.
Yeah, so I think for me right now, what I'm thinking about is thinking of my infographics. It's really important to me that they are inclusive of the LGBTQIA plus community. But I also know that I do work with patients that are a little bit older that might not have the kind of the comfort. And I also, the hospital I'm working with would like something that is, assigned at birth female, assigned at birth male to help with anatomy, which especially with spinal cord injuries is a huge part of it. The way that a spinal cord injury affects the different anatomies is important. But how do you address making that inclusive?
Well, so my advice for the second question that you asked about like having a pamphlet for I think like what the facility said was like for men and a pamphlet for women. What I would do is I would make it a pamphlet that talked about vulvas and a pamphlet that talked about penises.
Yeah.
And say like, don't use men or women or male or female, but say people, like just and all the way throughout, like you don't have to say like people with penises, but you just say like, some people may experience erectile dysfunction. Like we don't need to clarify with that these people have penises. Like it's an infographic essentially about genitals. Like we already know what we're talking about. So in some scenarios, like in a lot of scenarios, I would say like people with vulvas or people with penises, because but in this case, like, you couldn't say that in the beginning, but like really this is an infographic around like genitals and sex. So you just call them people. And so that's one thought. I think that's a tough question, like making things, I would probably like want to lean on some of my own peers that are OTs, sexuality specialists, and center and focus around LGBTQIA plus communities and populations. Like I'm not even certain I feel like 100% equipped to answer that question. However, the question really is like, what is our role in making infographics that are accessible to people? And so if people have the strong sort of bias and they don't want to have a pamphlet of like a straight couple and then a lesbian couple, like that's that gets in the way of their like access to that information. So I would love to just be like, well, then they don't get that information, but we can't do that. So I would probably want to consult that question and just reach out. Like, and what I'm doing here is just modeling like what to do when you don't know the answer. And just like reaching out to like other experts that are specifically like answer questions or would perhaps be better able to answer this question.
Absolutely. And I did see on your website or in the resources section, I do appreciate that you do link to some OTs that specialize more and have their own personal experiences in that realm. So I think that's really important. And I think, what you say about biases on your site, you are not a person that identifies in that community. And so it's important to center those views of people that actually do identify. But I think one thing as an ally that you can put, that you've talked about, is, in my pamphlets, I'm not just going to talk about penetrative vaginal and penile sex. There's so many things that we can do to make really simple choices and make it more conducive. Because I have, in my limited research, never really seen anybody talk about anal sex when it comes to spinal cord injury patients, which you do not have to be a member of any community to enjoy that. That's something that a lot of people in any community enjoy. So I think that's important, is just, opening the door and just saying that, like, sex is a very large umbrella term. So let's see what you need and where you fall in it.
Yeah, absolutely. And I do think as OTs, like we have to do so much advocating, and we certainly want to, like, OTs that don't identify within LGBTQIA plus communities, like we have to be really cognizant of taking on those efforts. So but like listening to the instruction, but also taking on those efforts, and advocating for our clients too, because I'm sure you're getting clients, like you're describing clients right now, but you're also going to get clients that do identify within LGBTQIA plus communities. So like we need to have information for them that privileges them over someone that is straight and uncomfortable with someone that is a lesbian or someone that is non-binary. Like I do believe, like, I don't have all the answers, but I will say, if we're going to choose one to privilege, do not privilege the discomfort of the cisgender heterosexual person. Don't do that. If you have to choose, then do not privilege that, because they have so many resources. They have so many other infographics, and they have so many other resources that they can go to. Whereas like so many other communities do not. So those are the communities that we have to privilege.
Absolutely.
Yeah.
Dale, thank you. And then my last question, when it comes to finding, or creating your infographics and your images, do you personally hire your own artists to create your images? Because I think that you've done a very fantastic job of showing intimacy in a way that does incorporate people, and interabled couples, interracial couples, everything that you can kind of imagine.
Well, it's so interesting. We'll talk about my images. Yeah. So I have an illustrator that I work with, but my images have gone through 3 rounds of revisions, or not even revisions, like 3 iterations and multiple revisions within each iteration. And I'm currently in the middle of a revision. And so I'm really excited. And that's kind of what I was sharing. Like, I've reached out and leaned on some of the other, like, OT, the OTs in this space that, like, don't have identities and experiences that are similar to mine and can offer a viewpoint that I could, like, never provide. And it's been it is such a fascinating and interesting process, like how people perceive images and how to make someone look a certain way. When we're also not trying to, like, we're also saying, like, hey, like, you can't tell anything about people from the way that they look. So, it's a very, or some client factors are not presentable, whereas some client factors are. So it's just it's been fun. I mean, it's a really interesting process, but yes, I would say how, like, what do I do? I mean, I work with an illustrator, and it's a lot of time that goes into making some images that feel more encompassing of a variety of ways of being, the varieties of ways of being sexual, and the varieties of people who are sexual beings.
Absolutely.
Yeah.
I think that's a really wonderful thing you've taken on. And that's definitely something that always jumped out to me when I looked at yours, was just how it felt like really, sounds kind of weird, like safe space image, and not in a bad way. It just like, it felt very warm and welcoming, which I think is a really important thing. So
awesome. Yeah. I mean, those are really meaningful, and I'm really excited to have that solidified probably by the middle of the summer. So
wonderful.
Yeah.
Well, I think that was all the questions I had for you. I really, really appreciate you allowing me to come on and interview you. It's been a wonderful experience.
Thank you. Yeah, no, you asked great questions and I really enjoyed it. So thank you so much.
Of course.